Good afternoon and welcome to United TV. It is time for Bariatric Friday. Today is April 4th, 2025. We are going to discuss another important topic for bariatric surgeries for those who are dealing with morbid obesity. And for whatever the reason is, it can be from complications, it may be inadequate results, there may be some new health concerns. Revision surgery is a really important part of the bariatric surgery. So as much as we focus on overall bariatric surgery process, pre and post, revision is another important issue that we need to discuss for those who know that there are other alternatives after they have their first surgery. And this is, we are going to discuss this. It can be, again, for many different reasons, but not every treatment is going to give the same results, and not every procedure and every treatment plan is going to be the same for everyone. So that's why we are going to have the area of expertise, Dr. Isaias Irgau, here with me. Dr. Irgau, how are you doing?
I'm doing great, Kemal. It's great to be back on another session of Bariatric Friday.
Well, it's always good to have you. So we are going to talk about the revision surgery, and bariatric is one of those touchy topics. Morbid obesity, we try to educate the public, be a resource for our patients who are going through the process. Yet this is still, limited understanding is still there. And revision surgery itself, when we say revision, it's almost like, I had these term issues from the early on when we had the gastric sleeve. I'm like, why are we calling this gastric sleeve? So this is, and I really thought that you were making like cutting the stomach, and then the extra pieces were being tied
Wrapped
and then
around it,
making the stomach smaller, but it wasn't that. It was actually really just cutting it.
Yeah.
So, and revision is like, we are not revising anything. We are actually doing another procedure. And then there are multiple options out there. But let's start with, why do we need a revision if bariatric surgery is the solution? I can see people thinking, hey, like I thought I was just going to be okay when I had the surgery. So if you can give us the background on the revisional surgery and why it's needed.
Absolutely. So as you correctly say, revisional surgery is a process whereby we go back and either tweak the first surgery in somehow, or we actually change it to a completely new procedure, right? So it's an intervention essentially on a pre-existing surgical procedure. Revision surgery as a whole, actually, as a term, is actually very common in surgery. You can have a breast reconstruction surgery that requires revision, either because the outcome was not the way the patient expected, or because there were complications that needed to be fixed. Or if we do surgery, for instance, to remove a tumor from the intestine, and we have cut out a portion of the intestine, and we have reconnected it, we may go back and do something different because there was a complication or another intervention was needed. So repeat surgery, revision surgery, is actually not unusual in surgery. So when we talk about revision surgery, we're essentially saying we are going back and undertaking an additional procedure or changing the procedure altogether. But the question that you raised at the beginning, which is really very important, is why do we need revision surgery in bariatric surgery if the bariatric surgery is the answer? Well, bariatric surgery is the answer. It's a treatment. It's a medically necessary treatment. And like all medical treatments, we don't always get 100% of the results that we expect. This is just not possible for any treatment in any field in
Not
medicine.
necessarily just for the surgical, but even with the medication, everyone is responding differently.
Absolutely,
right? Absolutely.
So why is bariatric surgery treated any differently than any other medical intervention, right? If a patient goes to a doctor because they have cancer and the doctor removes that cancer, but then the cancer comes back, you don't say, oh, we've done one surgery and we cannot repeat it. Well, if the problem exists, if there are issues that need to be addressed, the doctor needs to address them appropriately. So to expect bariatric surgery to have this unattainable standard of 100% perfection is just another symptom of castigating bariatric surgery into a stigma
right,
from which it cannot get out. Right? That's what they're doing. And this is actually real, Kemal. There are insurance companies, health insurances, that say, for instance, you're allowed to have only one bariatric procedure per life. Where is that coming from? Why are they saying that you can have only one shot at a treatment of this complex disease? Right? It makes no sense. They're doing it because they can, because there is such stigma against obesity that no one is defending the treatment for obesity appropriately.
So
right?
I don't want to take your attention to a different issue, but it's just like I couldn't help but just remember what happened yesterday, because it all comes down to the understanding of the industry and in some cases people. So when we do bariatric surgeries, in some cases where we may have the hiatal hernia, and for the relative value unit, the standard term, this procedure is 50% more complex than gastric sleeve.
Yes.
So when you open the patient, and in some cases we may know that they have hiatal hernia, but in some cases we don't know this until we open the patient. Now, you are there, you're a surgeon, and then the understanding of this medical director on the other side was, so there isn't enough documentation of this. I'm like, what documentation do you need? So I'm there. I said I'm there because I was like, you trained me so well. So then I kind of confused him. He thought I was a surgeon. I said I'm there. So then the patient's open, and then I see this more complex problem. Not only the problem needs to be taken care of, but if I don't, it's going to impact the outcome of the main procedure.
Yes.
And I put all the documentations out there. I put everything properly. And you tell me, your coder tells me. And no disrespect to anyone, but there's a surgeon who's deciding to do what's right versus there's some coder who doesn't have the same education and tells me, you don't have the right documentation. Then I said, so you want us to close the patient and they schedule them for 3 months, 4 months, and then taking care of the hiatal hernia at that time. That's a crime.
Yeah.
I said, that's a medical ethic issue where my surgeons won't be able to do that because it's not the right thing to do. So this is important because this is the, unfortunately, issues that we deal with.
Yes.
And
yes.
I was really upset. Now you can tell, normally I don't get hyper on these, at least in the show. So it just made me so mad.
Absolutely.
So I'm like, what do you want us to do, right?
Yeah.
So then I realized that he just doesn't know.
Yeah, and also because there is, there is this attitude of impunity when you attack bariatric surgery in any way, right? So they put patients, they put surgeons and caregivers on the defensive because they are taking care of obesity, right? A complex disease. So going back essentially to what we were saying earlier on is that a number of patients may require what we call revisional surgery, additional surgery, or repeat surgery, either because there have been some complications, right, some symptoms that have derived from a particular procedure, or because the patients have not achieved the weight loss that we want them or resolution of comorbidities that we want them with a particular procedure. The most common revisional surgery, as you know, is revising a gastric band to either the gastric sleeve or to the gastric bypass, right? When you compare the gastric band with the sleeve or the bypass, is clearly a weaker procedure in terms of its outcome. There's no question about it. The appeal of the band was because it's a procedure that is perceived as being less invasive than the other procedures. So there was a time in which patients really had a lot of gastric band procedures undertaken. Some patients did well, but others struggled because there were complications related to the band, or struggled because the weight loss could not be sustained afterwards. And because obesity comes back or the comorbidities return, patients rightly are requesting a different approach, a different surgery that will help them a little bit more, with more impact, which means removing the gastric band and then going ahead and doing a gastric sleeve or a gastric bypass. So we are doing revisional surgery in such situation. Another revision surgery would be to go from the gastric sleeve to gastric bypass, for instance. This happens much more commonly if there are symptoms that occur, for instance, after the gastric sleeve. One of the symptoms that can happen, for instance, is heartburn. Not everybody gets heartburn after the gastric sleeve, but some patients can have heartburn, and in a minority of patients, that heartburn may be very difficult to control, even with medications. In which case, we recommend surgical treatment, and the surgical treatment would be changing the gastric sleeve into gastric bypass. Because of the way gastric bypass is constructed, the anatomy actually prevents acid from going to the food pipe, and therefore the heartburn or the reflux is resolved. So the thinking behind revisional surgery essentially is to help the patient. Help them either because they're having symptoms that require intervention, right, to a different procedure, or because they are still struggling with weight loss. Now, there are a number of things that have to be considered before we recommend revisional surgery,
Right.
of course. One is understanding that revisional surgery is a step up in terms of the potential risks of the surgery, because we're operating in a field that is no longer virgin, right? We have intervened there, we have created scar tissue, and scar tissue does not heal in the same way as natural tissue would do. So when we intervene, we understand that the risks of the surgery are higher. A higher level of expertise is needed to undertake revisional surgery because of the complexity of the surgery itself. And then the other thing to consider is what is the likelihood that the revisional surgery will be successful? That we have to consider as well, particularly if we're doing revision surgery because the patient has not achieved the weight loss that they expected, or because they didn't see the resolution of comorbidities that we all expected. We have to say to ourselves, did the procedure fail to achieve this? Or did the patient really did not comply with what we asked them at the beginning? Because as we always talk about, bariatric surgery is a tool. And
Right.
the tool is as good as the person utilizing it. So we have to make sure that there are fundamental changes in lifestyle of the patient, right? Because you could end up in the same situation even after the revision surgery if those changes are not undertaken. So we don't take revision surgery lightly. It's not something that we do at the top of a hat. Obviously, we have to consider many issues, including, of course, the risks of the procedures themselves, the type of the procedure that would be appropriate, but also we have to consider how the patient handled themselves with the first procedure and what led to failure in the first place.
So the first lab band surgery, we were one of the first ones who
Yes,
did it in
absolutely.
Delaware. When was that?
That was, I believe, in 2002. Dr. Wynn and I performed the first lap band surgery in the state of Delaware.
So 2002 is 23 years ago. Ethan,
right.
how old are you? Okay. So this procedure is younger than Ethan,
Yeah.
right? Sorry, Ethan, I'm using you here, but since you are in your 20s, it's okay. So part that people maybe also are missing is it's so new. And in 2002, that's what was available to us.
Yes.
And then 23 years ago, like we talk about other treatment plans may fail, but they've been doing that for years and years and years. But the thing is, technology, medicine is improving
Yes.
and advancing. So then this is where now the band is not the only solution. So then we, in 2010, I believe we start doing a gastric sleeve.
Yep.
And so this is still so new, but then one of the things, like, from the clinical standpoint, you may not say this, but I don't have a license, so I'm going to say it. So there are patients today, if they are in front of us, band and sleeve, I'm going to say, okay, sleeve is what we need to go with. But when we didn't have the option of sleeve 12 years before sleeve was available, of course, so many of the revisions are actually coming from those bands, as you were saying.
That's true. That's true.
So, but it's improving.
Yes.
So now when the failure of sleeve versus band are not same, but still it's possible.
Yes.
And then when one of the things that we do gastric bypass, and bypass is the last kind of step in the surgery scale for us, but there are some patients, they may need to get the gastric bypass from the get-go, even if they are younger, because if they have certain conditions, we won't be able to gastric sleeve. So some of those things were not available to us before, when now technology is more advanced and we know and we have enough cases, enough outcomes to see what's happening. So I think, when someone gets a hair transplant, I think I used this example with Dr. Wynn the other day for something else, they get that multiple times. So, and the reason is usually not because they lose the new ones, because they still keep losing. So now they have to add more to cover the new loss. Okay. So no one is saying, hey, why are you doing it again? Right. So that's kind of like that issue will probably, by the time we do these for a couple more years, there will be enough people. Now, most importantly, we have auto dubbing now, so meaning that now we are available in 7 other languages.
Oh my God, that's amazing.
7 or 8. So you are pretty good in French. Dr. Gail Wynn is doing excellent in Portuguese, Italian, Hindi, German, Japanese, and there are a couple others. So now the more people are going to be educated with these, because we'll be able to reach out to more people.
Absolutely.
So
countries.
now the going back to the issue, as you were saying, that there may be some risk. This is at a next stage or next level in terms of what we are discussing in terms of the risk, and those needs to be discussed with the surgeons, and also what failed us in the beginning. Is it the type of surgery failed us, or is it our approach failed us?
Yes.
So this issue of compliance, because we do this every week, my mind works a little bit differently anymore. So everything that I do throughout the day, I try to see if there are any examples that may be relevant for what we are discussing. So last week, you remember my QuickBase database that I use for the weight, like the diet journey? I thought it was only 2 months ago when I stopped using it.
Yeah.
It was September when I stopped entering stuff. So I didn't think it was that long ago. But one of the things that I kept the same regime and same routine, so it was not anything different. But then I forgot how much, how quickly it's now, I'm not doing it anymore. So that means my compliance actually went down a little bit, because I know that I cheat a little bit more than I used to.
You don't document, that's right.
But then nothing is reminding me that. So this week I started again. Actually, it was last Thursday, I believe, I started entering. So the April entries are done. So, but then now I'm more careful, because I know that something is reminding me that. For October through December, 3 months, and then 3 months or 6 months, it was off the table. So I don't know how that happened.
Yeah.
So this is how easy to kind of fall out of the wagon. So it's just so easy. So, and I don't need to be on that every day, just entering everything, but I still do, because it keeps track of everything that I do, and then it reminds me of what I need to do. So patient needs to realize what failed at the first time, and they need to be honest with themselves. If they're having difficulties, they can come to the show and then I can talk to them about being honest because it's important, right? So if you don't know where the problem is coming from,
Yeah, no, that's true.
how are we going to actually address the main issues? So this is kind of like why morbid obesity is extremely complex, and it's not really easily understood even by some clinicians because it changes, it varies from one person to the other. So now, Dr. Ergau, before we go into more specifics, can we talk about the reflux? Because we kind of use that as it's kind of like maybe side effect of some of the, not side effect, the patient has the conditions, but with some situations, if they already have the bariatric surgery of some type, they may go to a reflux, and I want to make sure that we cover that in the revision side.
Absolutely. So heartburn or reflux is a very common condition in general, right? And it tends to be more common very often after the application of certain bariatric procedure, particularly the gastric band and the gastric sleeve. Not universally, but certainly more common. And in the vast majority of situations, heartburn is actually managed by dietary adjustments as well as utilization of medication, either on as needed basis or on a regular basis. But there is obviously a proportion of patients on whom these measures are not sufficient, right? In which case we can offer surgical solutions, right? So for the gastric sleeve, for instance, surgical solution for heartburn that is intractable and ongoing would be to switch the gastric sleeve into gastric bypass, which by its nature has really an anti-reflux anatomy, because the vast majority of the stomach.
Can you just repeat that again, like the last 20 seconds?
Yeah, absolutely. So if you take, let's compare the gastric sleeve and the gastric bypass. Okay, with the gastric sleeve, the food pipe, right, the portion of the digestive tract that is in our chest is still connected to the whole length of the stomach. Right. Although the majority of the stomach is removed, the length of the stomach is still connected to the stomach, right, which means that acid from that stomach can still potentially travel backwards into the food pipe and irritate the lining of the food pipe, which is not supposed to interact with acid. That is the key. So remember, we have a lot of acid, very strong acid in our stomach, but our stomach has a lining that is purposely constructed to resist acid. That's why we don't feel that, right? But the food pipe, its lining is not constructed to resist acid. Therefore, when acid travels backwards into the food pipe, that creates problems, including the symptoms that we get, but also irritation of the lining of the food, right? So if you take the gastric sleeve, what we've done is we've taken a big portion of the distensible portion of the stomach, and we've removed that, so the stomach is stiffer now, right? Which means the pressure inside that stomach can go up very easily and quickly. And that pressure can displace the acid in the stomach upwards into the food pipe, where the pressure in the chest is much, much lower, right? But if you take gastric bypass now, you have the stomach that is amputated very high up. So the lower portion of the stomach is totally separated from the upper portion of the stomach, which generally has no acid holes or has very, very little acid. Therefore, there is no potential for the acid from the lower stomach to travel back up into the food pipe, which means that if you change the gastric sleeve into the gastric bypass, you are automatically relieving the food pipe from the potential of being exposed from acid. That's why a surgical treatment of acid reflux on somebody who has a sleeve gastrectomy would be to change them to gastric bypass. Now, how often does that happen? Not very often, right? But because we have a lot of patients, very often we seem to be doing a lot of revisions. But really, clearly, the vast majority of patients who had the gastric sleeve do not require a revision to gastric.
Sure. Now, also, the term heartburn is, I think that's one of the American ways of making things more difficult. There's no heartburn, so your heart is not burning, right? So it's just reflux, backflow, like that.
Yes, that's actually a better term, right? Because heartburn implies almost as if the heart is involved.
Right, so it has nothing to do with that.
Yeah,
Now, But that's, again, I see that maybe the second most common that we do under the revision is
second most common, but way below the first most common, right?
Oh, yeah. So
way more.
There's a huge, like 87%,
yes.
and maybe this is 3 or 4%.
Absolutely, absolutely. So let's talk about the gastric band, because you raised a very important issue. You say that the vast majority of our revision surgery involves actually removing the gastric band and switching it to something like the gastric sleeve or the gastric bypass. And why is that? Well, the real answer for that is twofold. First of all, because the gastric band is a device. It's a device, and that can be removed. And that was actually the very characteristic of the gastric band that appealed to people. People like the idea they could have a device that could be taken out as well, right? That permanence of a gastric bypass or the gastric sleeve was not there. That was appealing to a lot of people, that they wanted the band for that.
Because as soon as you tell people that you're going to cut their stomach, that becomes
absolutely. And at that time, in fairness, at the time in which the gastric band was very popular, was also the time where the only other alternative we were offering was the gastric bypass, which is a step up, much higher step up in terms of complexity, but also long-term implications of the changes that the patient was incurring when they got gastric bypass. So needless to say, a lot of patients chose to have the gastric bypass, right? So the fact that it's a device that can be removed really means that there is much easier time in doing a revision. You can say, okay, let's remove the band and change to something else to address two problems, right? One could be a problem of inadequate weight loss or weight gain. That can happen with the gastric band. We know that in the realm of bariatric procedures, the gastric band is a relatively weak procedure when it comes to weight loss. So if you have somebody who requires extensive weight loss, the gastric band could take them just so far, right? After that, they may require something more powerful. So that's one issue with the gastric band. But the other issue with the gastric band, obviously, as a device, it requires really a very, very narrow window of adjustment of its tightness. So the amount of fluid you need to fill the band to get the person to feel satisfied and to feel not hungry is really very close to the amount that would cause the band to be too tight. So that window is so very narrow, and it could change from day to day, which means that patients may feel, okay, I have the good restriction now, I'm not hungry, I'm not eating too much, and then 3-4 months later, they could be having problems swallowing, obstructive problems that make really life miserable and quality of life not good. So that back and forth between not being hungry or not hungry, but having restrictions with vomiting, and vomiting that can occur in the most unpredictable situation, which means that patients will be at a restaurant eating, and then suddenly they have to go rush to the bathroom because they can't swallow things. So the band really becomes very inconvenient in this way. Right. But also that back and forth between it being too tight or not tight can lead to an exasperation of the patients, right? Where the weight really doesn't become a good focus by itself, and therefore they end up gaining weight. So it's not surprising that a fair number of patients who have the band, who've had the band for many years, decide at some point, look, I need a different approach. And the good thing is we can offer that approach. We can offer that approach because we have options that are less invasive than the gastric bypass. For instance, we can do the gastric sleeve. Also, the gastric bypass by itself is also an option. And these procedures, although more complex than the first-time procedures, can be undertaken with safety, particularly in very experienced centers like ourselves, right? Our center has a lot of experience with the gastric band. It has a lot of experience with the gastric sleeve. It has a lot of experience with gastric bypass. We're operating in an area of the body which is the same, right?
So nurses, they're the most knowledgeable in bariatric.
So we can offer revision surgery, these repeat surgeries, even in an outpatient setting, and we do it very often, essentially. So we have to get out from this mentality that bariatric surgery should be treated differently than any other surgical treatment.